have to keep a mask on. I'm in the OR, but everybody, how's it going? So thank you for the opportunity to speak. I wanted to thank Michael and Eileen for asking me, and I initially said no because I'm in the OR, and as you all know, the OR situations are quite variable, and we only have a few days we can work, but this was important to be part of, so thank you for asking me to be part of this. And of course, it's an honor to be here with everybody, except Keith Barton, who I'm not sure why he was invited, but he's going after me anyways. I am going to speak about something that really excites me, which is already in clinical use, but also is being evaluated in the preclinical world, and that is intraocular IOP sensors. There are many ways to measure pressure, and I'm going to focus on this. I do consult with a few companies that are in this space, including InjectSense and Glaukos as well. So, of course, we know that glaucoma, a leading cause of blindness, asymptomatic and insidious, and intraocular pressure is associated with damage. And it's a significant risk factor, and our treatment, of course, is based on this only modifiable risk factor. We, of course, aim to get low pressures with consistently stable postoperative IOP, and we know that medication adherence is also poor and increases the risk of progression. IOP, of course, is a part of every single glaucoma assessment around the world. It's typically done in the office with a single measurement, and of course is faulty because of the issues around the assumptions on the Imbert-Fick principle. It's also, of course, impacted by corneal biomechanics. And we know, of course, in a variety of studies that pressures do fluctuate significantly and often are more elevated at night when we can't measure the pressure than during the day. Conventional thinking is that typically peak IOP is where the damage typically occurs in glaucoma. Although it's somewhat controversial, it's these peaks that are likely most damaging to the retinal ganglion cell optic nerve complex. And this is where the progressive damage can occur. We also know these peaks can often happen outside regular clinic hours and may not be caught during just a single measurement. The under curve can also miss this as well. And a single pressure measurement, of course, is a very small time point during a patient's day. I apologize again. There's a code white. That means a violent patient. Now, we, of course, see different ways to measure pressure outside the eye. For example, rebound tonometry, we see the variation in pressures, even measuring them during daytime hours. So the problem is IOP assessment. Our current measurements require patients to make a visit in the office and have appellation measurements, which, of course, during this COVID era is a problem. It's non-physiological, inaccurate because of Imbert-Fick assumptions, and a single measurement is inadequate to capture the full IOP range and miss peaks. Of course, we also cannot assess compliance by measuring a single time point when a patient may have taken the drops right before the visit. The solutions and principles here, and there's a variety of companies in this space, is the implantable IOP sensor. We're able to, the goal here, of course, and the principle is to directly measure pressure in the eye real time and continuously. There are various ways to do this using active or passive sensing, wireless charging necessary, of course, because the implant's in a closed system in the eye. We have to get the data out by telemetry. We need to, of course, preserve tissue as much as possible, make it biocompatible, minimize the disruption of the patient's lifestyle, and have a long-acting product. These are 4 companies that are currently in development or have a commercial product: IOP Implant Data, Cora, InjectSense, and Glaukos. The sensors that are in development are either preclinical, animal, human, or commercial. A lot of these companies are operating fairly quietly, so there's not a lot that we can publicly speak about, but I'll speak about what's available and what we know. Of course, there's a variety of places these sensors may be placed. We can think most obviously, of course, in the anterior chamber, in the vitreous cavity, attached to an IOL. These are all typical places that we may look to in terms of where we may be able to measure, also the suprachoroidal space as well. Now, designing an IOP sensor, of course, is fairly complex, relying on engineering principles, surgical principles, and other material differences. Typically, this includes a MEMS sensor, mechanical electromechanical sensor, application-specific integrated circuit, and these can be either using active or passive electronics. These have to be fabricated in a biocompatible coating typically, and miniaturized, of course, to be in the eye. It's, of course, important to have an ability to wirelessly transfer and charge the implant with an external reader typically, and ideally these IOP sensors are autonomous, don't require patient interactions. We have to also compensate for drift as well over time, as these implants typically will reside in the patient's eye for many, many years. Active IOP sensor uses active transistors and diodes. This does provide a greater precision and reliability. but does require more power consumption, and we have to consider warming and temperature changes, typically done with a rechargeable battery. Passive IOP sensors like resistors and capacitors are less complicated and less power in terms of demand, but require, of course, frequent charging and wireless energy transfer of data. The iMate is probably the most widely known current IOP implant. As you can see, and this is a sulcus implant made of silicone. It's an encapsulated capacitor here with a thin diaphragm that basically deflects the pressure. This is read by an external source transmitted by radio frequency, and it can allow for frequent measurements. These are just some examples in terms of what the iMate is currently in, what its form it's in. There's a sulcus implant you can see that's already CE marked that can be placed in the sulcus or possibly the capsular bag. And then there's a product in development that is designed to be into the supraciliary space, suprachoroidal space, which is current in development. Here's just an example of the video on the bottom left showing the sulcus implant, a familiar space for many of us, where it would reside typically, of course, in a pseudophakic eye, either in concomitant or after cataract surgery. The ability to place a device in suprachoroidal space allows it to be placed here using an external dissection. Of course, as I mentioned earlier, it's important to have and collect the data, and this is typically done by a reader, which also charges the implant as well, and the data is collected and then can be provided in a proper format for evaluation. Data has been published here with the Argo studies with the iMate, and we can see long-term IOP monitoring with fairly good levels of agreement with Goldman applanation tonometry, and of course, work still has to be done in terms of looking at the correlation here as well. And one of the benefits is really being able to evaluate when these peaks may occur in a 24-hour period. And I think this gives us substantially more data than we currently get with current IOP measurements. Cora has an implant that's been implanted in animals. So you can see it's attached to an intraocular lens in this case. And further work is being done to further miniaturize this to be able to provide the implant in other parts of the eye as well, standalone. This again is a system that's designed to wirelessly read pressure and charge the implant, ideally without patient interaction, fairly autonomous, with simply, for example, a bedside external sensor or source that can be used to collect the data and charge as well and upload the information to the cloud as well. InjectSense is another device that's currently in preclinical work, and as you can see, this device is placed here very much like an intravitreal injection. This is more of an office-based procedure as opposed to a surgical procedure that we've seen with other designs as well. Again, the idea basically that this is an autonomous data collection that is obtained either with a pair of glasses or another source, uploaded, of course, to the cloud, and then, of course, relayed to healthcare providers. So from a patient's perspective, I think this reduces the uncertainty of the disease. Is the pressure controlled or not between visits? It will reduce likely the need to get back to clinic to measure pressures. Of course, we still need to be evaluating visual field and optic nerves. It possibly eliminates the need for applanation tonometry. And of course, the idea is we can proactively now identify the patients that may be peaking that we can perhaps treat more aggressively, eventually improving quality of life and, of course, providing further cost savings to the system as well. From our perspective, of course, this is the holy grail of glaucoma and the holy grail of IOP monitoring. Continuous IOP monitoring, of course, will allow us to hopefully adequately assess risk assessment for a patient, decide on the best medical and surgical therapy, and I think also acts as a compliance tool. Is my patient taking their drops? We'll be able to look and see, of course, in terms of how the IOP control is, and of course, the ability now to use big data and AI, of course, adds further benefit here. There are certain corneal conditions where it's difficult to measure IOP, if not impossible, like, for example, patients with keratoprosthesis is an obvious one. And also surgical real-time measurements during VR or cataract surgery may be a benefit, again, to provide enhanced fluidic control in the eye as well. We also know that there's an increased incidence of glaucoma in patients who have intravitreal injections, and this is the ability to measure this, of course, during these injections and assess for potential acute IOP spikes. So why am I excited? Well, I think this is, again, as I said, this is bringing IOP to the digital age, right? This is 2020. This is the holy grail of measuring IOP. Goldman is quite antiquated and really not appropriate, I think, in today's world. This can also provide an ability to provide enhanced IOP metrics like percent peak or area under curve, for example, that may be more relevant than single measurements as well. And as I said before, big data will, of course, guide us as well. The ability to provide this as a feedback loop to link with drug delivery and outflow devices, again, to control aqueous flow will be the ultimate, very much like we see, for example, in the advanced diabetic monitoring and treatment devices. Surgical IOP monitoring, as I said earlier, and of course, there's also other applications in the body, including neuro as well. So quick summary in terms of why I'm excited about IOP sensors. I apologize for being in this getup and being in the OR, but thank you again for having me here.
Thank you so much, Ike. Very, very nice, very excited talk, very nice topic. I will ask very quick question. As a refractive surgeon, I am asking this. I apologize. This is really very different technology, very different field for me. You implant is into the eyes for a period or long term? How long period will stay in the eye? And another question is, you implant is which patients? What is indication?
Yeah, great question. I think the first question is yes. I mean, that's a very good question as far as the duration. These implants are hopefully designed to be in the eye and be active for 10, 20 years. There is, of course, it's important to compensate for drift, which typically would occur, and there's ways to compensate for that, as well as fibrotic growth over the implant as well. But the idea, of course, is to have this implant, at least in these current designs, longer term. Now, there are other ways to look at it for short-term evaluation that may not be as stable, but the value here really is for longer-term evaluation. That is still, of course, something that is still, needs to be evaluated as far as the durability of that approach. In terms of the other question was in which patients. I mean, I think ultimately, really, anybody really who has real glaucoma needs to have the IOP measured. Anybody where we have to make a regular IOP assessment, and we use that in terms of disease management, I think is a candidate for something like this. Obviously, if we're already going into the eye doing cataract surgery in a glaucoma patient, this provides an opportunity since we're already in the eye. I think for patients perhaps that are progressing and have normal tension glaucoma, that we're not quite sure, are they not compliant? Are they spiking? Are they peaking? Or they truly have not normal pressure glaucoma or a non-IOP mechanism? It can be useful in those patients. So that will probably be the first wave of patients I think that we look at particularly. And obviously in your world, in the corneal refractive world, anybody who's got really bad corneal pathology, keratoprosthesis, I mean, that's an immediate first place to look for, of course, in terms of where we would think about these devices. It's already, of course, being done and published in K-Pro as well.
Thank you so much. Keith, do you have any question, any comment?
Unmute, Keith. Yep, there you go.
This is obviously the the future, and it is one of the most exciting innovations. And it's we've actually been waiting for this to come along for some time, because any kind of intraocular sensing will be a game changer. Ike, can you foresee these getting into phakic eyes, for instance? Obviously, cataract surgery is the low-hanging fruit, but I mean, are any of the devices you're working with really going to be suitable for phakic eyes, or is it purely going to be, for a long time to come, purely going to be limited to cataract surgery?
I think it's a good question. I mean, the hope, of course, is that it'll be a broader application, and the designs that are attached to lenses, of course, are restricted in that way, or to a capsular tension ring. However, some of the companies I just mentioned are working, for example, on a transscleral pars plana approach into the vitreous cavity. That would, of course, be a patient that wouldn't require or be done with cataract surgery. Other companies are working on an anterior chamber implant or angle-seated implant. Those would be examples where we would not need to. And of course, also, as I mentioned, suprachoroidal measurements, if one looks at that aspect of it as well, are avenues. So I think we all have the what's that?
That would be very different. It's negative.
Yes, I mean, there have to be a lot of compensation, and there's a lot of pros and cons in whatever approach we use, whatever space we do. But again, those I think are where they are. And we can, of course, debate whether we should be looking into the vitreous or suprachoroidal space or anterior chamber or capsular bag. I think those are all good questions that I think we still, of course, don't have full answers for.
Yeah, this is such an exciting area. The other challenge you mentioned already about fibrosis, how to actually power the things. And I know that some of them work on induction. I presume there isn't any of this depending on some kind of battery. That's completely unrealistic, I guess.
Yeah, I mean, there's clever ways to charge these devices, and in fact, rechargeable batteries have come a long way and miniaturized. They do, of course, limit the duration in terms of which they'll be usable. But the way we've all seen, I mean, our iPhones in terms of how they progress with battery life, and I think the same thing we're seeing now, the ability to attach to a MEMS device as well. So I think that's where we are seeing miniaturization and longevity with novel ways to charge, which is what I think we're seeing in the preclinical work.
Brilliant, great presentation. It's such an exciting area, and it'd just be nice to see something getting a little closer to clinical practice.
Absolutely. Stay tuned.
Yeah.
Okay, thank
you
you so much, Ike, again. Have a nice surgeries. Have a nice day. Thank you so much between surgeries joined us.